Right, I'm gonna get started then. Hi everyone. Thanks for joining us this afternoon on Monday. After Thanksgiving, my name is Ueda. I'm from North Carolina State University. This journal club, I'm going to talk about the kidney biomarker based on this recent paper published in this year. Assessment on the cell cycle arrest biomarkers and the neutrophil gelatinase-associated lipocalin to distinguish AKI from other diseases in dogs. Before just gonna jump into this paper, I'm gonna kind of quickly review the kidney biomarkers. As you guys all know, there are so many kidney biomarkers. Some of them we use in the clinical settings, and some of them are based on research investigations. But all these kind of biomarkers can be categorized in three different types or categories. One of three is functional kidney markers, and then the another one is active kidney injury markers, and then the last one is stress markers. And this stress markers is the main one that we are going to talk about today. So again, a quick overview. Oh, sorry, this my PowerPoint's doing something crazy. Just gonna. Hmm. All right. It just automatically kind of just kind of moving the pages on. I don't know why. Okay. Ooh. Hold on. Mm, all right. Okay. It doesn't stay here. I don't know why. All right. The functional kidney marker is one that we usually use in the hospitals and clinical settings, as you guys know, such as serum creatinine, SDMA. These are the conventional markers for the kidney function, mainly like surrogate markers for the GFR. And these conventional markers or functional kidney markers reflect collective or global functional kidney mass. Like you can see, that's the collective function of the many millions of the single nephrons. And each nephron has a GFR, and the global function is that there's this GFR. And when they have that loss of the nephrons, they might lose the number of the nephrons, but some of the remaining nephrons can increase the GFR and the function. Overall, they can still maintain the global or collective function of kidneys. And that's what you are measuring based on the functional kidney markers. So they might not be able to get at it to identify the ongoing active kidney injuries. And then the one of the functional kidney markers is of course the serum creatinine. Another one that we often use in the clinical settings is SDMA, symmetric dimethylarginine. And like you guys know, this is early markers for the diagnosing on the CKD. And also it is known to be increased in an AKI, acute kidney injury patient as well. Like these studies in 2017, JVIM showed that increased the SDMA concentration of serum in the dogs with AKI. And the same as in the CKD, the values of the SDMA in these two groups were higher than the healthy control groups. However, there are not significant differences between the AKI and the CKD groups. And also, this SDMA concentration is slowly going up, and it takes time to increase in higher than normal reference ranges. So it's not the early diagnostic markers on the AKI, kind of similar to that in the serum creatinine concentration. So when you are trying to, sorry, that they're still kind of doing a little bit kind of weird movement, but hopefully I can still kind of stay in this slides that I'm trying to show. So back on the slides, again, that the two diagnosing the active kidney injuries, there are many studies investigating these new biomarkers, again, called active kidney injury markers, which include urinary NGAL or urinary cystatin B and many others. By using these active kidney injuries, we are trying to detect this actively going on kidney injuries and hopefully phenotyping this AKI, such as true AKI or subclinical non-asthenic AKI, and also the hemodynamic or volume responsive AKI. When the patients have the increased active kidney injury markers and also the functional markers, this patient might have the true AKI. When they have the increased functional markers, but there is no increase of the active kidney injury markers, this patient might have the hemodynamic or volume responsive AKI, or maybe previously called pre-renal AKI, pre-renal asthenia. When the patients have the active injury marker positive, but negative functional markers, this patient might have the subclinical AKI or non-asthenic AKI. So you might be able to get the more phenotype or subgroup on the AKI based on that this active kidney injury markers. And also that you might be able to determine the progression of the kidney diseases, especially that when you are talking about the progression of the CKD or acute on chronic kidney diseases. And one of the most commonly investigated this active kidney injury markers is urinary NGAL. NGAL is a neutrophil gelatinase-associated lipocalin, NGAL. It's one of the lipocalin family proteins. And this protein is released by the many cells, including neutrophils and epithelial cells, including renal tubular epithelial cells, tubular cells. And these proteins, NGAL, they're produced in the systemic circulation. Again, for example, the neutrophils or other epithelial cells outside of the kidneys can be filtered through the glomerulus and reabsorbed by the proximal tubules. So when there is a kidney injuries, especially at the proximal tubules, the reabsorption of this NGAL protein is going to be decreased, and that is going to increase the concentration of the NGAL protein in the urine. Also, when there's a kidney injuries, the expression of this NGAL from the distal tubule cells is going to be increased by more than 10 times. And that could be another source of the urinary NGAL concentration. So based on that, these kind of the expressions and decreased reabsorptions, urinary NGAL can be increased in the patients with active kidney injuries. And there are many studies, even in the human patients, even the dogs, and there are some in the cats. This is one of the study published in 2020. They looked at this urinary NGAL concentrations in a various different type of disease patients, including AKI and healthy control patients. And what they found out is that the patients or dogs with AKI had a higher urinary NGAL concentrations compared to healthy control dogs, like you can see in the very left corner of this graph. So y-axis in this graph is urinary NGAL concentration. And a healthy dog and AKI, the patients with AKI had much higher concentration of the urinary NGAL compared to healthy patients. They also found out the patients with inflammatory AKI or AKI with the inflammation such as pyelonephritis, patients could have a much higher urinary NGAL concentration compared to the non-inflammatory AKI patients. This is probably due to increased expressions and the production of NGAL from neutrophils, white blood cells, in the urinary system. Then if you look at the reading these papers, and then if you're doing the research, you might encounter this idea of measuring the urinary biomarkers in the urine, and that these concentrations normalized to the creatinine concentration. Or sometimes you hear that the urinary biomarker to the urinary creatinine ratio. And the reason to normalize this biomarker concentration in urine to the urine creatinine concentration is to avoid the variations in the urinary biomarker concentration caused by the altered urine concentration. But this idea or the process is a little bit kind of controversial. because there are some issues with measuring that the urine creatinine concentration and normalizing the biomarker concentration to the urine creatinine concentration. Because that this urine creatinine concentration is unreliable in the disease condition that affect creatinine excretion, such as AKI patient or CKD patient. And also that these creatinine values can be influenced or impacted by the muscle masses and the creatinine metabolism, same as that when you measure serum creatinine concentration. But this the normalization to the urine creatinine concentration has been still investigated, and this is one of the studies in 2013 show that this urinary NGAL to the creatinine ratio, or sometimes we call UNCR, has that showing that the significant elevation in AKI patient compared to the healthy control and the patient with CKD and also patient with lower urinary tract diseases. So like you can see on this graph on this slide, the y-axis is the urine NGAL to creatinine ratio. And the patients with AKI, grade 1 and also grade 2 to 5 had a significantly higher UNCR compared to dogs in a CKD, lower urinary tract disease, and control groups. And there are some other calculated variables that you can get based on that urinary NGAL concentration and also the serum NGAL concentration. This is the human patient study published in 2022, looking at the ratio of the urinary NGAL and the serum NGAL ratio, so US NGAL, or fractional excretion of the NGAL. And they find out that the patients with AKI had significantly higher this urinary NGAL to serum NGAL ratio and the fractional excretion NGAL compared to patients with CKD. And the reason I'm talking about these variables on the NGAL is that because that's what they calculated or measured in this study we're going to talk about today. And finally, this is the main the markers that we're going to talk about today based on this paper. That's the stress markers. That's they are used for the early detection of the AKI before kidney injuries, and also that that is used to predict the risk of the AKI development. And then if you look at this, sorry, just keep moving. Look at this phases or stage in the AKI, you see that the days in the x-axis and the y-axis and G alpha, the very, I'm pretty sure you see that this graph from before. And then these phases in the AKI include initiation, extension, maintenance, and recovery phase. And when you use that, the conventional functional kidney markers like serum creatinine or serum SDMA, we probably diagnose an AKI and at the end of the extension phase. But if you use that this active kidney injury markers, such as urinary NGAL or UNCR, creatinine ratio, that you might be able to diagnose an AKI much earlier, probably toward the end of the initiation phase. But by using this kidney stress marker, we might be able to find out diagnose the AKI or the patient who has high risk of developing the AKI at the beginning of the time phase when the actual kidney got the insult. And one of the kidney stress markers that has been investigated is also called the cell cycle arrest markers. These are the markers or molecules that are released in response to noxious stimuli like stress in the kidney cells, especially in the tubule cells. And these two markers and molecules are called urine tissue inhibitor of the metalloproteinases 2, TIMP2, and insulin-like growth factor binding protein 7, IGFBP7. So these are the one that they are measured in the urine after they are released from the stressed tubule cells. And then these the molecules are involved in the G1 cell cycle arrest, probably as a part of the protective mechanisms when the tubule cells are feeling the stress or going to be injured. when these tubules cells get the stimuli or noxious stimuli, they're trying to conserve the energy by decreasing the expressions of the ion transporters, such as sodium potassium ATPase, and also trying to decrease the protein expression, protein productions in the tubule cells. And this is a way that they can try to prevent from the cell death due to cellular energy failure. And again, in more details is described in this figure. So what happens is that when there is a cellular insult or stress or stimuli to the cells, tubule cells, that these tubule cells produce TIMP2 and IGF-BP7 molecules. Then these molecules act like autocrine or paracrine molecules, and they bind to that, this luminal surface of the tubule cells, and they induce the expression of the P proteins, including P27, P53, and P21. And these P proteins actually block or inhibit the expression or production of the cyclin-dependent protein kinase. And this cyclin-dependent protein kinase that is produced in these tubule cells are actually promoting the cell cycle. But this promoter of the cell cycle are inhibited by this P27, P21, P53, so that eventually this TIMP2 and IGF-BP7 plays a role to induce cell cycle arrest. And this TIMP2 and IGF-BP7 has been investigated in a human patient for the last maybe 10 years or maybe over 10 years. And this is one of the kind of the first papers published, and they looked at these two markers, stress markers, and especially the product of these two markers. So urinary TIMP2 and urinary IGF-P7 product. And they've find out that these product of these two markers are the is an excellent predictor of the AKI development in the critically ill patients or people undergoing high-risk surgeries. And they compare to the many other active kidney injury markers and functional kidney markers, such as urinary NGAL and urine KIM1 and cystatin C. And like you can see, this x-axis is the area under the curve. So it's showing that these two stress markers and also the product on these markers has a higher area under the curve or a better predictor of the AKI development in the ICU patients. So this one is actually showing that the same things, kind of showing that this TIMP2 and IGF-BP7 markers and the product these two markers can be utilized to identify that the patients who has high risk on developing the AKI due to the stress to the tubule cells or to the kidney cells. And this test has been commercialized and FDA approved in the human patients, and it's called a NephroCheck. There are two types of tests or devices that the human patients or people you can use. One is actually that the kind of big machine that you can access in a central lab, and this immunoenzymatic test can run at this TIMP2 and IGF-BP7, and you can get the results within a few hours. This left one is more like the benchtop test. It's not made for the point of care testing, but you can actually measure these the molecules TIMP2 and IGF-BP7 within the 20 minutes by the bedside. So it's kind of utilized as a point of care testing in a human patient. So now, finally, going to this journal, the article that I would like to discuss. Again, this is about this TIMP2 and IGF-BP7 stress markers, and they also measure NGAL and also SDMA, kind of trying to pick that these stress markers, active kidney injury markers, which is NGAL, and the functional markers, which is SDMA. And they kind of compare these different type of markers in the AKI patients and also other disease conditions like CKD and critical illness and healthy condition. So the hypothesis of this study was the urinary TIMP2 and urinary IGF-BP7, these stress markers, are increased in dogs with AKI and can be used to distinguish from the CKD, healthy, and critically ill dogs. Again, to test this hypothesis, they evaluated the urinary TIMP2 and urinary IGF-BP7, and also NGAL and SDMA in the different group of patients, group of dogs, including AKI, CKD, and also healthy patients, and also critically ill dogs. So they have the 4 groups of patients, and they measure all these biomarkers in this group of patients. This is at the inclusion criteria, showing that the AKI group, the CKD, and then the critical illness group patients. And again, another group is healthy group patients. And this inclusion criteria, the AKI group dogs in the AKI group had acute onset and clinical signs less than 14 days. And also that these findings and images, especially in ultrasound, abdominal ultrasound, and urinalysis, are consistent with AKI. Regarding the serum creatinine, they included dogs with a serum creatinine more than 1.8 milligram per deciliter, persistent after correcting pre-renal factors. So they kind of they give the fluids and they're trying to correct in dehydrations. And even despite these corrections with a fluid, still serum creatinine concentration is higher than 1.8. They included them in the AKI group. They also included patients, dogs with a serum creatinine concentration increased more than 0.3 milligram per deciliter within 48 hours. But based on my reading, I believe that all these patients still had higher than 1.8. So they are still asthenic and also having more than 0.3 milligram per deciliter increase of the serum creatinine within 48 hours. The dogs in the CKD group had a clinical signs and history consistent with the CKD, and also the images and the urinalysis findings are consistent with the CKD. All these patients in this group also had asthenia with a serum creatinine more than 1.8 milligram per deciliter. The critical illness group, CI group, is that the one that admitted through the ER due to that systemic illness or critical illness. And they kind of define a critical illness based on the Apple FAST score. This Apple FAST score is determined based on the 5 parameters, like you can see on this right side of this slide, including glucose, albumin, lactate, platelet count, and the mentation score. So this is kind of abbreviated version of the Apple score. Apple score is that the canine acute patient physiologic and laboratory evaluation. This score has been validated to determine that the illness severity of the patients, especially in the emergency setting. Then these patients who are included in this group had more than 18. So it's kind of moderately critically sick patients are involved in this CI group. But this group did not have the patients with AKI, CKD, and post-renal asthenic patients. I believe this group of patients had the patients with pre-renal asthenia, meaning that they're having the high serum creatinine concentration at admission. But eventually, if these numbers goes down to the normal values after fluid resuscitation, these patients could be still included in the CI critical illness group, not the AKI group. So after admission, within 4 hours, they collected the blood and urine sample, including the urine collection by cysto or UCAT or free catch. They're trying to get all these urine samples, same as the blood samples, before fluid administrations. But again, some of the patients got the fluid administration for the resuscitation ER. And at that time, they're trying to get the urine sample within the 2 hours after initial stabilization with a fluid administration. They measured TIMP2 and IGFBP7, these are stress markers, by using the sandwich ELISA. And one from the ABCom, and another one is from my biosource. They did in-house, or they did validation of these kits by using the urine samples. These biomarkers, ELISA test, were commercially available for testing or measuring the concentration with these markers in the serum, not in urine. So they tested it and by using the urine sample and trying to validate it. This is kind of some details information about the validation results, including lower limit and detection, intra-assay, coefficient variation CV, spike and recovery, and linearity recovery. These numbers are, I'm going to say, acceptable, not the best numbers, especially that if you look at this spike on recovery, that's ideally from the that should be between the 90 to 110%. It's a little bit kind of out of that, this range, ideal range. And the linearity recovery, I believe that usually that's acceptable if that's from the 80%, 100%. So it's a little bit kind of less than the 80%, especially in IGFBP7. So these numbers, not that the best numbers, still I'm going to say acceptable, but maybe there are some more validation might be necessary, especially for the IGFBP7. Regarding the TIMP2, again, this validation test is okay, but this lower limit detection is a little bit kind of too high. So maybe there's some like the additional test, or the additional test is necessary, or you might have to be careful when the patient have the very low number concentration of TIMP2. The other things they did, again, like I kind of mentioned in the introduction, they looked at the more the calculated variables of the urinary NGAL or NGAL concentrations more than just urinary NGAL or UNCR. They looked at this urinary to serum NGAL ratio by looking at it, again, urinary NGAL divided by the serum NGAL concentration. They also calculated urinary to the serum NGAL ratio, and also this urinary NGAL concentration is normalized to the urinary creatinine concentration. They also looked at the fractional excretion NGAL by measuring that the urine, the NGAL concentration and creatinine concentration in both serum and urine. And as a result, they have the 10 healthy dogs and 11 CKD dogs and 11 AKI dogs and 10 critically ill dogs. And the 11 CKD dogs included their 9 stage 2 and then 2 stage 3 dogs. And there are 2 grade 2 AKI dogs, and then 3 grade 3 AKI dogs, and 2 grade 4 AKI dogs, and 3 grade 5 AKI dogs. And these AKIs were due to leptospirosis, hypercalcemia, pyelonephritis, and then 4 of the 11 dogs had unknown cause of the AKI. The critical illness and these dogs admitted in the ER and enrolled in these studies are due to acute hemorrhagic diarrheal syndrome, or HDA, and septic peritonitis, acute hepatopathy, IMHA, Amanita toxin, and DKA. And this is a clinical pathological data, kind of baseline data for all these kind of study groups. Like you can see, serum creatinine concentration was significantly different between these among these groups. But as you can see here, this kind of showing that the median and the range of these values, and the critical illness group patients, the highest number of the serum creatinine concentration was 2.3. That is higher than the 1.8. So it does look like there are some patients have the higher creatinine concentration than the normal. But again, assuming that these patients got the normal values after fluid resuscitation. And then also the AKI group had all patients AKI group had higher than 1.8 serum creatinine concentrations. So again, this study included the AKI and the IRIS AKI grade 2 to 5, not including the grade 1. So going to that, these results and the measurement of the urinary TIMP2 and the urinary IGF-BP7 concentrations. And this table kind of summarize or look at showing that all these kind of measurement numbers, especially the median and also range of this concentration. And then what they looked at is, again, like in the human studies, a human patient, they looked at the raw measurement of the urinary TIMP2 and urinary IGF-BP7 concentration. And also they normalized these values to the urinary creatinine concentration. So ratio they looked at. And also they measure the product of these two marker concentrations. And also these product of these markers are normalized to the urinary creatinine concentration. And I'm going to show that this graph of these measurements. So this first slide here, within that this urinary stress marker results is that the urinary TIMP2 concentration. So this left graph on this slide showing that the raw concentration of the urinary TIMP2, like you can see, the dogs in the AKI group had significantly higher concentration of this urinary TIMP2 compared to the CKD group and the critically ill group. But this urinary TIMP2 to urinary creatinine ratio, so normalized the creatinine ratio, had the better results or more distinction between the AKI and other group patients. So with that, this ratio of the urinary TIMP2 and the creatinine ratio, the AKI group had a significantly higher concentration of TIMP2 compared to healthy control group and the CKD and then critical illness group. Looking at the urinary IGF-BP7, the raw data was not significantly different among all these four groups of patients. Healthy, CKD, AKI, and the critical illness group were not statistically different. If this IGF-BP7 is normalized to the creatinine in the urine, the AKI group had a significantly higher the IGF-BP7 concentrations compared to healthy group and compared to healthy group. Now, this is a product of these two markers. So TIMP2 multiplied by the IGF-BP7. Still, AKI group looks higher than the other group, but there was not statistically significantly different, except that the differences between the AKI group and the critical illness group. But if this product number, two markers product, normalize the urinary creatinine concentration, or this ratio to the creatinine concentration in urine, the AKI group had a significantly higher concentration of this product, or that the number of this product of these markers compared to healthy CKD and the critical illness group. So far, as I mentioned, urinary TIMP2 to the creatinine ratio, and also urinary TIMP2, multiplied by the IGF-BP7 to the urinary creatinine ratio, had the kind of best results to differentiate AKI to the other disease groups and the healthy control. What about the urinary and the serum NGAL concentration? Again, they look at urinary NGAL, serum NGAL, and then the urinary NGAL, urinary creatinine ratio, so UNSCR. These three markers or measurement were higher in dogs with AKI than the healthy dogs. So compared to control, they are all significantly higher. But there is no significant differences between the AKI, CKD, and the critical ill dog groups. What about some other new variables of this NGAL? So this is the urinary or urine to the serum ratio of the NGAL. And these numbers are significantly higher in CKD, AKI, and the critical illness group patients compared to healthy group controls. This is that the urinary to serum ratio of the NGAL, but also this urinary NGAL was normalized to urinary creatinine. And then by looking at this, the ratio normalized to the urinary creatinine, the AKI group had a significantly higher than the healthy control, but there is no significant differences between the CKD and the AKI and then critical illness group. So all these three groups were not significantly different, but all these three groups had a significantly higher this ratio of the NGAL compared to healthy control group. Lastly, this is a fractional excretion of the NGAL in these four groups. And like you can see, the AKI group has significantly higher this fractional excretion of the NGAL compared to healthy control group and a critically ill group. But there's no significant differences between the AKI and the CKD. So overall, like this urinary NGAL and also this ratio and fractional excretion, all these kind of variables in NGAL are significantly higher in the AKI group compared to healthy control group. But it was hard to differentiate or differentiate the AKI to the CKD patients. And finally, the SDMA is the one that they measured as a functional marker. And then they the cutoff that the SDMA is a 15 microgram per deciliter. And all patients with the AKI had an SDMA higher than 15, and then 10 out of the 11, so almost all CKD patients had SDMA is higher than 15. But the 4 out of the 10 dogs in the critically ill patients also had an SDMA higher than 15. Then this AKI group had a significantly higher SDMA concentration compared to healthy groups. But like I said in the previous studies, this AKI group and the CKD group, their SDMA concentration were not significantly different. Again, same as the NGAL, the SDMA, serum SDMA were not able to differentiate AKI and the CKD based on that their SDMA concentration. So, like I already mentioned here, so far that the main findings in this paper is that the urinary TIMP2 and the urinary IGF-BP7, these are stress markers, could be measured in the canine urine by using this sandwich ELISA markers. And also, the urinary TIMP2 to urinary creatinine ratio, or the product of these two markers, normalize the urinary creatinine. These two measurements or the calculation variables were significantly higher in dogs with AKI compared to dogs with a CKD, critical illness, and healthy dogs. And like I said before, all NGAL variables were significantly higher in dogs with AKI compared to healthy dogs, but there was no significant differences between the AKI, CKD, and the critical illness groups. And the same as SDMA. SDMA concentration was higher in the AKI group compared to healthy control groups, but there is no differences between the AKI and the CKD group. So going to discussion, again, like I said in the main findings, these two variables, like urinary TIMP2 and urinary creatinine ratio, and the product of the TIMP2 and IGF-BP7 normalized to the creatinine in the urine was significantly higher in dogs with AKI compared to all other groups and including healthy dogs. Despite this, there was a considerable overlap in biomarker levels between these groups. Like going back to these graphs, you can see there's a significant differences, but still some of that AKI patient had close to normal values if you look at these graphs. And some of the healthy patients, the CKD patient, and the critical ill patients are very high this urinary TIMP2 concentration or the IGF-BP7. So it's not that they're 100% accurate to distinguish AKI to the other groups. And then some of the main some reasons is that this AKI group of patients might have the lower values than that this should be, maybe because these stress markers, that these patients with AKI, or the established AKI patients have the decreased cellular stress already because they already have that this established AKI with high serum creatinine concentrations. And the cell cycle arrest markers like TIMP2 and IGF-BP7 concentration in urine may be highest when they have stress when they are developing the AKI, not after AKI is developed already. So these cell cycle arrest markers may have the greatest diagnostic utility in early or developing stages in AKI. What about the high values in the other groups? That could be just errors or the measurement, but also that could indicate the cellular stress. These patients might have the actual cellular stress in the tubule cells without developing the AKI. So after stress, they kind of conserve the energies and then just did not get the injuries and they just recover from the stress. Or they might have the progressive CKD, and then they might have the ongoing stress on kidneys, especially in the CKD group. So that might be the other reasons the CKD patient also have the high stress markers. And in human patients, these the stress markers, and especially the product of these two markers, is used to identify the patients with a high risk of developing that moderate to the severe AKI after surgeries. So this is one of the studies looking at these stress markers as early biomarkers and acute kidney injuries and renal recovery after cardiac surgeries. Like you can see, this is cardiac bypass patients. Y-axis is this urine TIMP2 and IGLBP7 product or concentrations. And the x-axis is time after surgery or bypass procedures. And when they have the AKI, these values actually increases even within 4 hours and 12 hours, 24 hours. And these patients develop the AKI with increased serum creatinine concentration after 1 to 2 days 1 to 2 days after the procedure, surgery. So clearly these numbers goes up in the urine before they show the clinical signs and before they show the increased serum creatinine concentrations. And again, that the other potential benefit is to be able to run or measure these concentrations of these stress markers on the bedside if you use this acute meter to measure these stress markers. So what about in the dogs and the cats potentially? Well, can we use these markers to predict the development of the AKI in high-risk patients, such as ICU critically ill patients, patients with a sepsis or systemic inflammation, trauma patients, and also, of course, on toxicity cases, and maybe some high-risk and their surgeries cases. We might be able to identify which patient needs to have that more active monitoring or aggressive monitoring the treatment to prevent AKI, or maybe having that extended treatment and monitoring the ICU because of that the high stress markers. Even if the serum creatinine concentration is normal, then we might change our treatment and monitoring protocols in these patients. And again, that the urinary and the serum NGAL can be increased due to in the AKI patients and much higher than the healthy control patients, but I might not be able to differentiate AKI and the CKD groups. Just gonna recap this urinary NGAL concentration may increase or may result for the increased tubular expression and or decreased tubular resorption. But also, again, the urinary NGAL may be due to pyuria or systemic inflammations. So again, back in this study, they had this high urinary NGAL patients, and that some of these patients, but because I don't think that they rule out the pyuria in the urine before they measure the urinary NGAL. So it is possible this pyuria or neutrophils in the urinary tract system might falsely increase the urinary NGAL, even that the patients in the CKD, AKI, or critical illness group. And again, these other variables, calculated variables of the NGAL, including a fractional excretion of the NGAL, were higher in the AKI than the CKD. Actually, well, not higher than CKD. Oh, that's right. Sorry. Well, these variables were higher in the AKI group than the CKD group, but there is no statistical differences. This could be because of such a small samples with type 2 error. Or maybe there's a patients with a progress CKD patients. Just kind of going back then the results on these studies and looking at this NGAL, like I said, there's no significant differences in CKD and AKI in a statistical analysis. But if you look at the graphs, there are quite big differences. Again, did not reach that, the statistical differences. Maybe that is because of such a small sample size. And if they have more cases, they might see statistical differences between these two groups. And as serum SDMA concentration were also increased in both AK and CKD group, but not different between these two groups. And also some critical ill dogs demonstrated high serum SDMA levels that could be potentially due to early signs of AKI in these cases or altered SDMA metabolism. So as a limitation, this study, again, a small sample size, and an AKI group, the AKI group only had the iris AKI grade 2 to 5. And probably, if you're looking at this as stress markers in a clinical settings, if we're using these markers, it may be more interesting in evaluating these dogs with grade 1 non-asthenic AKI, or those at high risk of developing AKI, yet there is no AKI developed yet. So that's going to be interesting to have the patients with iris AKI grade 1 patient. And then it is possible that there are active kidney injuries going on in the critical ill groups and the CKD groups. And again, I believe that they did not rule out the pyuria before they measured urinary NGAL. So that if there's any lower urinary tract infection or pyelonephritis, there might be some influences from the neutrophils in the NGAL concentration in urine. They did validation of the ELISA kits for this TIMP2 and IGFBP7 stress markers, but these are the acceptable results, but there is not that, they're perfect ELISA test. So there might be some like an adjustment and the modification might be necessary. Especially in the IGFBP7 might need some adjustment. So question for the future research, the question is that how can we use these the stress markers and utilize to predict the development of AKI in dogs? And which patients are most likely to benefit from the stress marker testing? And how much benefit could patients get from the test? And how should the test results be interpreted in the clinical settings? And what specific actions or interventions should be taken based on test results? And also, we just talk about in dogs and people. Can we actually measure these stress markers in the cats? And finally, the same test devices, especially that need this point of care or bedside measurement marker, the device to measure the stress markers used for the applicable to the veterinary patients in dogs. Based on my quick research, these stress markers and these molecules are quite similar in the human beings and canine. I did not check that in feline cats, but in the protein composition, the DNA, the sequence are very, very similar. I believe the 97% similarities. So there's possible that we might be able to use in this bedside or point of care testing devices to measure stress markers in the future. But of course, we need further studies and validations before we using that in the clinical settings. I'm sorry that I had some like issues in my slides, kind of keep moving on without touching the computers. So just kind of having a little bit kind of going back and forth. But hopefully there are some like new information for you guys, and I'm more than happy to answer any questions at this point.
Dr. Ueda, I don't know if you can see the chat, but there is a question in the chat.
Oh, okay, hold on. Okay, the question is, do you know what happened to the stress markers and fluid response for AKI patients? I would assume that could increase since the kidneys have been stressed by hypovolemia. But you were saying they will have excluded them and put them on the control group or the critical L group. Do you think that could be? Yeah, I agree. So the question is that these volume responsive patients, having the high serum creatinine but went down to the normal values. My understanding is that they are included in a critical illness group, not the AKI group. And I believe, yes, these patients could have the stress to the tubule cells. These two stress markers are known to be increased, not only by the sepsis, but also the inflammations, even toxins or ischemic injuries. I believe that there are some stress, and that could actually influence and bias potentially the results. Yet still, if you look at the TIMP2, normalize the serum urinary creatinine, and also the product of these two markers, normalize the urinary creatinine, was significantly different between the AKI and the critical illness group. So the results might be same, but I agree. I think that these fluid responsive AKI patients could change these differences in these two groups. Well, thank you for the question. And if you guys don't have any other questions, I'm going to finish here. Thank you for joining us.
Thank you so much.
Thank you.